So I'm so grateful for our relationship with the Marquise team, and I have such respect for the work that you guys do, and I thank you for the opportunity to come and talk today. As Alicia said, my name's Orlaith Finucane, and I'm one of the clinical leads for palliative care at John Hunter Hospital, and I've just started in a role as a clinical lead for Hunter New England. What I really wanted to say was acknowledging to you, the audience, that the whole ethos of palliative care is to have an individualised approach. And if I met you at the hospital this afternoon, I would do my homework and look at the scans that you've had and the people that you've met along the way and what's happened. But then I wouldn't ask you to repeat all of that because I could see what's on the list of priorities for the doctors. But I'd want to sit down and find out what the priorities are for you. And I would talk about telling me to stop if I ever gave you too much information, and I would try to follow your lead. And I'm really conscious that I can't do that for a room full of people today, and that you're all at a very different stage in your story. So if anything that I talk about today is confronting or triggered, please reach out separately if you'd like to talk at another time or to come through the Marquise team to chat again. And equally, I'm not planning to say anything confronting to have you have to leave the room today, okay? But I also won't be offended if for any reason you do need to step out, so please feel free to come and go, okay? My aim is not to overwhelm you at all today, but it is even a triggering word, palliative care, sometimes. And so I just want to explain what support is available as best I can to a room full of people who are in a very different space at different times. So what is modern palliative care? And I'll be honest with you, we desperately need a rebrand, because I think everybody knows that we deal with death and dying, and yes, we do, but in modern palliative care, we do so much more. And what we'd like to be rebranded as now are symptom specialists, because that's very much where we've come to the fore in knowing people much earlier in their journey and their story. Or quality of life specialists when you're facing uncertainty and you're facing that unknown and scary part. Sometimes we're the team that can come and spend more time. And I want to make it clear that nothing's off the table to talk about, but again, we'll follow your lead with that. And my message today is really that palliative care is about helping people to live as well as they can for as long as they can. And I'd like to talk a little bit more about that. This image is what's called the bow tie image. So in old school palliative care, we came in at the very end and we were there for end of life. And absolutely that's important, but this is what we do now. So you'll see on the left side, we're really happy to meet people right from the point of diagnosis. And we might be only a very small part of your care team then, but we'll always work alongside the big team that you deserve when you're facing something so challenging. And it may be that over time, for some patients, not for everybody, that we become a more important part of that team, and we may play a more dominant role, obviously, towards the end of life for some people. But it's just to get that sense of, you might want to check with your doctors at what point they think you're meeting us, because there's a lot of misconceptions and fear when the word comes up about I'd like you to meet the palliative care team, and perhaps it's worth unpacking that to know. So I'll try to do that a little bit more now. What does it entail? So you'll see first the small little inner oval there, that's that bit about end-of-life care. And we do recognise death as a part of life, and we are experts in that space. There's a lot we can do to provide comfort and dignity, but what I really want to draw your attention today is the big oval. So I want to focus on that period where actually sometimes we know people for many, many months or many years. We might dip in and out of your journey as you need us, as much or as little as you need us, but just to be aware of that. And there's lots that we do. What we do is try and find out what's important to you. And that's where early referral actually can be really useful, because we get a chance to know who you are and who your people are. And that's the best way we can advocate and support you in your individual space. Our job is to respond early. So if there's something interfering with your day, so a symptom or a problem or a worry, well then we want to step in and try and focus on that, help people to do what matters to them. In that sense that Mark said about focusing on each day, well, what's interrupting that and stopping you getting to do the things that you want? We really focus on experience. So symptoms, is that's where that comes in. What's your experience like every day? And also your function, what are you able to do and not do? To do this, we rely on a really impeccable assessment of what's happening. So we might do a really deep dive and have lots of questions, but there's a reason for that because it guides us on the best way to approach it and sometimes helps us to sort of think outside the box with symptoms. Symptom management, I think, surprises people sometimes what it entails. So sometimes that puts us in the position of advocating for things like surgery or for procedures, or talking about things that we think might buy you time or might buy you comfort. And so we sometimes are even in that space of saying, actually, I think it might be a really good idea to consider something here. It might be invasive, but there might be a really good benefit. So sometimes it's really a very, very active space that we work in. And the message for patients, I think, is to know that often symptoms can be managed well. They're tricky symptoms when it comes to brain cancer, but there's things that can really help. And certainly there was lots pinging for me in James's talk about steroids, as I could see nods around the room. But sometimes we have some other things that might help as well, just to try and take that or spare the steroids a little bit if there's other medications that can step in and help. I'll talk a little more in a minute about goal setting and future planning. But the other thing I wanted to emphasise is the psychosocial support that comes from palliative care too. And again, to echo Mark, that's really important for carers too. And you need to feel valued as a carer because you're right alongside someone who's been diagnosed with a brain cancer and you're on that roller coaster too. Facing an illness like brain cancer is just so stressful for your family, and you know that far better than I can ever pretend to. It's just that sense of how it affects your thinking, your fatigue, your mobility, and your role in your family. And both as the person with the diagnosis and the carer or the loved one, you're not failing if things are difficult. And that's really important to say openly and overtly. And the potential new tensions in your relationships, that's not personal and it's not you, it's the illness. And sometimes it really helps to have support in that together and separately, and we'd like to offer that. So what palliative care entails, look, it's come a long way, so it's very much a multidisciplinary team now. So it's got a really strong history of palliative care nurses, and I'm very biased, but they are a very special breed, much like the brain cancer nurses. But we've also got palliative care doctors now, and the specialist training has come a long way in recent years. And then we have a whole team. So it often surprises people to hear that we have palliative care physiotherapists, that we are trying to improve function and to help work in that space. We've got occupational therapists, Aboriginal health workers, and really importantly, we have bereavement counsellors and social workers too. There's a number of different arms, and I guess I didn't want to go too much into this because it's slightly different in each place, but if anyone's got individual questions, really happy to answer them. It's such a big area, Huntington, England, and it might be different in your locality. But we work alongside consult services in the hospital. So this afternoon I'll see patients where the surgeons are their main doctor, but I'm there to try and help set them up for the weekend and to look at the sense of, is there information missing? Have they got gaps? So sometimes we've got time to go into that communication side of things and help bridge the conversation with the teams when things are really confusing and complex. And we also want to work on comfort for the weekend. Are you going to be able to enjoy those visitors that are coming in to see you? So that's the space we work in the hospital, and people will often call us if someone's got tricky pain or vomiting. And then in the community, there's a whole range of options. So we've got a variety of clinics or seeing people by video on telehealth, if that's easier and possible for you. And then we've got people who can come and do home visits, so actually come and see you at home. And I think that's one of the beauties of palliative care. We can hopefully be across that transition between the hospital and the home space. And then we've got the hospice. So in Huntington, England, we don't have enough beds, I'll be honest, but there is an inpatient unit in Tamworth. But the really only specialist hospice is at the Mater, and it's only got 16 beds. But the reason I want to mention the hospice is because, again, there's a bit of misinformation that the hospice is somewhere that you go to die and you never come out of the hospice. And absolutely some people choose to go there for end-of-life care, but we have patients who actually use the hospice for that specialist symptom management that we talked about, and they might come in and out of the hospice to get on top of their symptoms and go home again. So it's just to sort of demystify that a little bit. So when to think about referral? So absolutely, if there's complex symptoms, then hopefully your doctors might be thinking about us, and that's why they might bring it up with you. But equally, if there's a patient-reported symptom burden, so if you're struggling with something, that's enough to ask to meet us to see if we might have an idea or a thought that would be helpful. If there's repeated unexpected hospital admissions, so things aren't quite going to plan, is there something that we can come and do and help and support and see if there's things we can turn around or change? If you have difficulty tolerating goal-directed therapy, so that's really important, and I'll talk a little bit in a minute about really wanting to be on that fight with you. And if there's a symptom that's stopping you being able to have the treatment that you need from James, well then it's really important that we've thought of everything to try and limit that symptom before anyone has to think about stopping treatment. Worsening functional status, as we said, so it's getting harder to do things, then we'd like to meet you as well. And really, if a really important one is about if someone wants some help in what we call advanced care planning. I'll talk a bit more about that now. So what is advanced care planning? Advanced care planning is about planning ahead while living well. And I do agree with what Mark spoke about earlier. You can chunk this into what you can cope with, and it's often very much about taking things day by day. We have a lot of catchphrases in palliative care, but I think for good reason, because they are quite meaningful and true. And one of them is a sense of hoping for the best, but preparing for the worst. And that can be really important for people who've faced a really scary diagnosis. I can't say strongly enough, we will be your cheerleaders. So we will be there hoping that the treatment goes well and hoping for whatever your goals are. So we are absolutely there with you in whatever your top priority is at the time. And we can plan ahead without taking away hope. And that's really important. We want to be positive. But I know these discussions are hard. Thinking about the what if is really tricky. Most people that I meet after they go there and navigate those tricky conversations, if it's done in a safe and supported way from the right people, they actually express a real relief. Yes, it was hard to go there, but I feel better having taken the lid off that and talked about it in the right place at the right time with the right people. And having these discussions and how we have them is just so important. It's not possible for everyone, and I just want to say that we'll respect that if it's not for you. But we want to know that you have the knowledge that you need to make the choices that you can. And this is a really important way to do that. There are private aspects to this for you and things you'll want to think about yourself and things you'll want to talk about with your family, but you deserve the support to have the accurate information that you need alongside that. So we talk a lot about values-based outcomes discussions. So what's happening to me and what's a reasonable chance of reversibility with the goal of quality of life? And they're not buzzwords, they're really meaningful. So quality of life is a completely individualised thing. It's not about what I think is quality of life or what anyone else thinks, it's about you. And I think for most people, absolutely it's about survival time. Of course it is. But it's also about what does that time look like for me and my family? What does that mean? It's usually a combination of function of what you can do and your cognition and your communication and what level of support you're needing and also where you want to be, what your preferred place of care at different times is depending on how well or unwell you are. And talking about some of this or exploring it gently helps people to decide what they do and don't want from their healthcare providers. And I think when we talk about what you don't want, I really want to stress that putting limits on your care and saying that there's things I don't want, that does not mean that you don't receive care. And people worry about that. If I say I don't want that, what does that mean for the rest of my care? Well, actually, you're never going to stop getting care, and sometimes it helps us to be really, really active to make sure you get the things that might meet your goals. So it's really good to have them nutted out as best we can. And the other thing I put there was just to review it regularly. So things change, right? If you think about how you thought about things at the very point of diagnosis, and then as your experience changes, you can't always predict what you might think, which is why someone like me who hasn't faced the diagnosis personally, I can't imagine what you might think. And so it's really important that we check in occasionally to see where are you up to with that, or did that come any clearer for you, or any questions that you have. There's just so much we can do to keep you comfortable, and I think that sense of there's no such thing as a silly question, and I'd like to leave a chance for some questions at the end or privately at another time, because I can guarantee you if you've had a worry or a wonder that a family has probably had that before, and that you're not alone in that sense of what if, or that little niggle that you haven't had the chance to say out loud. When it comes to planning for the very end of life, that is very personal and it's really optional. But for some people, it's really important to be allowed to talk about that. And families often share with us that what they were thinking about quietly was actually much harder than talking about it and maybe filling in some of those really important gaps. We know that most people don't want to die, but a lot of people want to feel that sense of what might my dying be like, and they might want to have some control over the process as much as they can, or to understand it as best they can, but there'll never be any pressure to discuss that if it's not the right feeling for you. One thing that I think is really important to name up, and I hope that it's changing, but there is a misconception and an inaccurate sense, particularly from the past, that palliative care speeds up dying. And we actually have research papers now that show that that's not true. Sometimes knowing us can actually prolong survival, which is quite heartening to hear. But I do want to reiterate that we don't speed up dying. Some of you may be aware that voluntary assisted dying is legal in New South Wales now, and that's a separate team to us. We are absolutely happy to talk about these things if you want to, but only if you want to. And it's really important to reassure you that we'll be guided by you. And again, to be really clear that we don't hasten death. So I think I just wanted to mention some of the formal things. So a lot of people that I meet are often more worried about their family and their loved ones than they are about themselves. That would be a really common thing. When I ask what you're worried most about, people go straight to my children, my wife, my partner. And that's something that we like to talk about because you can't always predict what will help them. The thing to know about having some of these conversations can really support your families, and it's a very brave thing to do and to go there and to try and think around the what if part. If you are well and you can tell me what you want, I will always talk to you first, and you can change your mind as often as you like. So these things that I'm talking about, they only come into play if you were ever too unwell to tell us what you want. And what that does is really support your family and your doctors to decide what's in your best interest and to make sure that we're doing right by you. So the picture that's there is from an advanced care directive. So again, that's an optional document about your medical wishes and what would and wouldn't be acceptable to you. That's the standard New South Wales version. It's okay and it's a good place to start, but I would use it as a conversation tool to chat with your clinicians about, to your trusted person to say, actually, can we talk about this a bit more? For example, this one says personal values about dying, and it should actually say personal values about living. It's got nothing to do with dying. It's actually about what's your life like and what would be okay with you and what would not be okay with you. So those things can be really helpful to sort of stimulate that conversation with family, particularly to discover there might be things that you say, I don't know what I think about that, that's fine. What we actually want to draw out is the bit where you say, actually, I have a really strong opinion about that. And it can be really helpful to get that across, and to have your families know that is so helpful because they don't feel alone in decisions. They're just doing what I said about following your lead. I think the other things that are there to mention, so you can go to a solicitor and have an enduring guardian or a power of attorney, and that's different in every state, but in New South Wales, enduring guardian is having a surrogate decision for health matters, and then power of attorney relates to finances. And it can be so helpful for families to have this done so that in a stressful time, if they do need it, they're not scrambling to try and sort out something or find that they can't because it's not possible. Again, these are optional, and I know that for some people it's not an option by preference or maybe just by the cards that they're dealt in the way things go. But if you've got that chance to do these things for your family, I'd really recommend leaning into that and getting the right supports. One of the things when I put up personal affairs there is a tricky thing to talk about, but having a will And a lot of patients I meet say, I don't think I need a will because everyone knows what's to happen and I don't have much anyway, or reasons why they think it might not be important. Actually, it's so helpful for families to have one done, even if it's a really basic one, because what it does is take away all sorts of complicated bureaucracy later and time. So when someone's grieving, to have something that's drawn out and really tricky is hard. So I definitely recommend having a will if you can go there, and it doesn't have to be a fancy, expensive version. Legacy building is really important, and that's something that I really like to talk to patients about because, again, that's a different answer from everybody, and I love hearing what people have to say about their lives and what's important for them to convey to their families and their loved ones and to the next generation and to all the people who they've met who've been good to them along the way. And our social workers in particular are amazing to talk to you about this stuff. So if there's things that have been on your mind about what you might like to do just in case, well, then we're here to talk through that conversation with you. I wanted to talk a little bit about the concept that hope can change over time. And this is often really meaningful for families who've been unwell for some time and have been on that roller coaster, and this really resonates and helps them to feel seen because it's something they recognise. And again, it's that sense to say that palliative care don't take away hope, and we want to stay optimistic with you. But often we can help people to focus on what they might hope the most for now. So that might be hope for treatment and for cure. And like I said, we'll be rallying with you for that. It might be hope for meaningful time or family connection. And it might be hope for staying at home or at least being at home for as long as possible. And they're all really important real life things that happen in your world outside health, right? Your time in meeting us in hospitals and appointments becomes a really big thing, but actually what matters most is your home life and your universe and your real world outside of the clinical side. And certainly that hope for comfort and peace, I think, is always there every single day from the moment you're hit with this huge challenging diagnosis. We always want comfort and peace in your day in whatever way we can help support that. So I put up this quote because Dame Cecily Saunders was the founder of the hospice movement in the UK. But what we're really trying to say is that no family should ever feel alone in trying to navigate this, in the same way that Mark recognised that you needed the angels in the corner over there, because actually you deserve support with this and you should not be alone. And asking for palliative care is not a sign that treatment has failed or that anyone is giving up. It's an extra layer of support for you as patients and as families and the people who love someone who's going through something so tricky. We just want to be part of that support crew and an extra layer in that team. Any questions or comments that you'd like to discuss? Thank you so much for sticking with me. It's not an easy thing to bring up or to discuss, but I really appreciate your time and the fact that you're here today.
Does anyone have any questions for Orla? If you have questions that you want to take alongside, well, that's totally fine. Is there any questions that anyone want to ask while Orla's on stage? Oh, I've got a cat.
Well, I just wondered if you could explain to people how they might be able to see you, just so that it's pretty fast for them to understand.
Yeah, absolutely. So it's slightly different in every area, but I think the main thing to know is you just have to ask. So ask your oncologist, your GP, you can call the local palliative care service, but maybe you already have a clinician who can do that for you and take away any barrier that's there. If you're in hospital, like anyone at John Hunter can ask to see me and my team, and we'll always respond to that. We'll check in with your doctor so that everybody knows we're coming and what the discussion is, but it can be directed by you if you've got a concern or a worry. Then there's lots of ways to get access to us. So if you know the gang here, it's very common that Alicia or Sophie will give us a call in the hospital and say, please, can you come and meet this family? I really think there might be a benefit here that we can value add to what's happening. So I think just ask. Hopefully you have a support crew and someone you trust, And even if they don't know how to find us, they can go and give us a call and we'll navigate that depending on where you are and who your local service is. Happy to be more specific in that if anyone's got a question.
Is there any other questions for Orla?
I might just add one little thing to Bradley's question about, because it comes to us all the time to talking about cannabis and prescribing. And I think the main thing I wanted to say was exactly echoing James. It's about what it does for you individually and not missing if it's making something worse. So for some people, being on cannabis actually makes them nauseous and vomit, and sometimes it's missed that that was the change point. But for some people, they find it enormously helpful. And I think the big thing for us is to tell your care providers that you're on it. So people have a lot of shame about being on cannabis, and there's definitely no need for that. It's much better if we know, and there'll be no judgment here. Also because it interacts with other medications, so depending on what you're on, it's worth us knowing. It is where we would lean into trying to get a prescribed version, knowing that they're expensive. But at least then we know what's in it and what the components are and what the mix and the variance is there that will try and help us guide what it means in all the other therapies we're trying. But I agree, it's completely individual. The evidence is not what we were hoping for. So I think in our space, we were really hoping for some really strong, clear guidance from the evidence, and that's not what's come. But you know what, this is a very difficult space to do studies in, and you know that as a group it's so hard to match that really individual experience to raw numbers and data. So we do our best. Everything we do is evidence-based as much as it can be, but it's also important to think about the person and think outside the box and what might work in the individual nuances to your story.
Thank you so much.